Good afternoon. My name is Raimund Helbok. I'm Associate Professor of Neurology and Neurological Care at the Medical University of Innsbruck in Austria. On behalf of the Prospective Studies Group of the current Coma campaign, I will present the results of an international survey on the definition and management of coma, which is named Come Together Survey and is currently under review in neurological care. So let me start with some background information. Coma is quite common in neurological care and also in general critical care. And when we thought about initiating the survey, it was clear that we lack of a uniform coma definition, and the large variability exists in the assessment of comatose patients, in treatment modalities, prognostic issues, and also in available resources. And that's why we thought there is a need for a common definition of coma itself, of the data elements, so CDEs, and also about the treatment and the prognostic approach. This is our group, the Prospective Studies Working Group in the current Coma campaign, international experts in the field, clinicians, neuroscientists, and also nurses. We had three main objectives. First, the hypothesis that there is a variability in coma definition. The second objective is to find out about existing and commonly used assessment tools and also treatment strategies in comatose patients. And the third, attitude towards prognosis. We aimed to reach out to healthcare professionals working with coma and DOC patients. The survey was initiated in September 2020, and also the results presented on the World Coma Day and at the NIH meeting. The survey consists of 5 sections with 44 questions, where we identify the respondents in terms of demographics and years of experience in specific working areas in the acute care or chronic care. Then we provided the definition of coma and quantified the agreement to an expert's definition. And then we asked the respondents about the etiology of coma, management of patients in coma, and attitudes toward prognosis. All data were stored in a REDCap database hosted by the Medical University of Innsbruck in Austria, and this study was also approved by the local ethic committee. So participants, respondents were close to 260 healthcare workers. And if you see these 5 packages of questions we raised, we got a very good respondent rate. Also, those who did not respond to specific questions, up to 12%, did not differentiate from other who responded to this question in terms of years of experience or specification. So finally, we reached out to 41 countries. You see the main contribution from US, but also a significant contribution from Europe, Asia, Latin America, and we also reached out to Australia, New Zealand, and Africa. Respondents to the survey were mainly physicians from academic centers, which is important in the interpretation of the results of the study. The affiliation was mostly to neurology, some to critical care, and in terms of the subspecialty, neurocritical care is the most representative field. There was a large homogeneity in terms of the years of experience. A quarter had experience up to 10 years, but you see also a big contribution of healthcare professionals who are working in the field since quite a long time, more than 10 years. So one of the objectives of the study was the definition of coma. As first step, we provided cardinal features of coma, which we selected as international experts, and we asked participants to select all of these variables which, to their mind, define coma. a median of 4 variables were selected, and there was a large variability, especially in the combinations. We found more than 89 combinations in the selection of these cardinal features. From a statistical point of view, we analyzed the agreement. There was in none of these variables a perfect agreement, a substantial agreement in 6 of 8 variables, and only a moderate agreement in 2 of these variables. And only 15% of the respondents actually agreed to all the definitions provided by international experts. For the rest of the questionnaire, it was important to provide a common definition of coma. So we defined 4 core features, and importantly, point 5, to exclude the influence of pharmacological treatment, paralytic agents, and the use of sedatives, and also to clearly differentiate patients with cognitive motor dissociation if the testing was available. As next step, we asked for the agreement to the provided definition of coma. The participants could select between full agreement and fully disagreement by providing points. And again, we did not find the agreement for the whole definition provided in all of the participants. Interestingly, 28% either disagreed or strongly disagreed with the whole definition, which was also reflective for each of these subcategories provided. It is important to mention that the ones who disagreed or so strongly disagreed with the definitions did not differ in terms of country of origin, in the setting, years of practice, or even in the subspecialist. So further results in terms of etiology and assessment of coma. Etiology, the most common etiology was traumatic brain injury, as expressed by the blue bars. But if we weight the top 5 most common coma etiologies, it was intracerebral hemorrhage, followed by traumatic brain injury and subarachnoid hemorrhage, cardiac arrest. And there were also some other etiologies uncommon, like encephalopathy, sepsis, encephalitis, meningitis, autoimmune disease, and so on. The assessment of comatose patients, interestingly, the clinical examination was the most important diagnostic tools, supported by different scores like the GCS score, but also some other scores. But interestingly, the CRSR was rarely used, but this is also maybe influenced by the selection of participants, which mostly took care of acute coma patients. Another interesting feature what we could detect is that diagnostic tools, which are more sophisticated, are rarely used, even in academic centers, and stopping sedation protocols were not available in a substantial number of centers. The diagnostic approach in terms of EEG monitoring in general, there was a good coverage of EEG monitoring, and also a lot of centers specified the use of continuous EEG monitoring, but if it comes to a full accessibility and integration, the availability was less. But important to mention again that this study mostly reflects academic centers with a subspecialization of neurocognitive. We also asked the participants to provide us information about pharmacological interventions they usually use to stimulate arousal in comatose patients. I think the important information is that sedation vacation is important, sedation reversal is important, looking for differential diagnosis like electrolyte or endocrine disturbances and correction of these disturbances. And pharmacological interventions, the most prominent, 50%, was amantadine, followed by modafinil or dopamine agonists. Non-pharmacological interventions were rarely reported, sensory stimulation 33%, but are the rest in the minority of patients. What about prognostication and future research, which is obviously important for the Curing Coma campaign? Interestingly, the majority specified that etiology of coma is the most important prognosticator in comatose patients, followed by the information of neurological exam and imaging results, and also age contributes as prognostic factors. And only a minority see the preference in EEG findings, in the pre-morbid condition like frailty scores, or the fMRI findings. It is important to mention that we only ask for the selection of the top 3 prognostic factors, so this obviously also drives the results. We also asked for the availability of a formal policy of withdrawal of life-sustaining therapy, and as indicated by the response rate, we see that the majority does not follow a formal policy, and also in many of the sites, no ethicist is involved in this treatment decision. Discharge disposition is an important point as we lack of longitudinal data in comatose survivors. Although 47% indicated the availability of rehabilitation service in the healthcare system, vice versa, 53% indicated that they do not have a rehabilitation service directly available in the healthcare system, which is obviously important. And if we think about the longitudinal observational study, the partnering with a single rehabilitation center is only available in 10% of the respondents in linking the ICU setting to rehabilitation facilities. We also ask for areas of focus for future research. Treatment is obviously very important. Pathophysiology ranks as the top most important in the selection of 3, but also prognostication and diagnostic approach in comatose patients. So most respondents indicated, and I think that's an important information also for the Curing Coma campaign, that they would participate in further surveys. They also would support prospective observational studies in a follow-up period up to 6 months, or even 70% indicated more than 6 months, so up to 12 months after the acute care in the ICU set. In summary, we can say that we found a poor overall agreement on the definition of coma. There's a large variability in management of comatose patients, not only in the diagnostic approach, but also in the pharmacological approach. A large variability on the availability of the research facilities within their healthcare system, and the majority indicated to participate in a longitudinal cohort study. This is also one of the important future directions of our subgroup of the Curing Coma campaign, to design and initiate a pragmatic multinational cross-sectional prevalence study on comatose patients in the ICU setting, but also to link the acute care with the subacute and chronic care, to first identify the real-life situation and management principles of comatose patients, but also to more allude on the trajectory of comatose patients. So finally, I would like to thank you for your attention, and again emphasize on the fact that all what I provided is a team effort of international experts of the Curing Coma campaign, of the subgroup prospective studies. Thank you very much. I'm open for discussion.